In this presentation, we are going to focus solely on osteoarthritis. So another name or another abbreviation you might see for osteoarthritis is degenerative joint disease, or DJD. It's the most common form of joint disease, and there are two classifications. So your primary, idiopathic, basically just saying we don't know what was the cause of the osteoarthritis. Or there's secondary osteoarthritis, which could be as a result of another condition, such as rheumatoid arthritis, obesity, injuries, that kind of thing. So one of the biggest risk factors for osteoarthritis is age, over the age of 40, and then increases with age as well. So over 85% of the population over the age of 65 has osteoarthritis. Women have a higher risk factor. Genetics, just predisposition. Some people just genetically aren't born with good cartilage, good amounts of synovial fluid, that kind of thing. So genetics plays a part. Hispanic and African American individuals have a greater risk. Obesity, this is the most modifiable risk factor with diet and exercise to help prevent osteoarthritis. Laborious occupations, such as like construction workers or like individuals who do concrete, just what you think about that causes those wear and tear, overtime, repetition, jobs can really put somebody at great risk for osteoarthritis. Those that play sports, again, it's a lot of that just repetitive movement, torque, and everything on the joints. Any previous injuries to a joint, and then also muscle weakness would be risk factors as well. So what we're going to do here is pull up and briefly talk about the pathophysiology of osteoarthritis. If you haven't done so, I really suggest, again, you go look at the osmosis video on this. They do a great job of helping break down the pathophysiology of arthritis. But, when you look at a normal bone, you have articular cartilage that kind of, covers the end of each bone. Then underneath that articular cartilage, you have your subchondral bone, which is kind of the shock absorbing area right underneath the cartilage. And then in between the two bones in that joint, you have your joint cavity, which has your synovial fluid. And, synovum actually comes from the word that is similar to egg whites. So that's that liquid. It's kind of that almost like a slimy, but it helps really lubricate that joint and helps with movement. So your articular cartilage is lubricated, again, with the synovial fluid. It's a smooth tissue that protects the bone from damage with physical activity. And then between the articular cartilage of the bones forming the joint is that joint space that allows for movement. So with OA, what is happening is that cartilage on the end of your bone starts to break down. And what is happening with the breakdown of that cartilage is it breaks off and it starts floating in your synovial fluid. And your body doesn't really like that. That's called joint mice. And what happens is then your bone really tries to start protecting your body from those little joint mice, and they kind of suck it in and pull it down, and then they start using your immune response. So they start sending in those macrophages to try to fight them off. But in the process of doing that, there's the formation of osteophytes, which you guys have heard of, like bone spurs that start protruding on that joint. So then that joint space becomes very narrowed, and it's then puts more risk for narrowing of that space. Then once you start losing your cartilage, then you start just having bone on bone. And then not only that, you have bone on bone with spurs, or you have all those little osteophytes. So it's like those bones start rubbing together and they've got jagged edges. That's what then will cause the discomfort and pain that comes with osteoarthritis. So this is actually a great breakdown of the pathophysiology. So as you can see, one, it's not just simply wear and tear related to aging, which is what a lot of individuals thought over time. It is just kind of how it was classified. And they even thought that, with itis, we think that inflammation and everything, there used to be thought that that was a misnomer, that we was incorrect, that inflammation didn't play a part, but in fact it does. So when we look at this flow chart here, so we have whatever the case may be, previous joint damage, a mechanical injury, genetic and hormonal factors, any other factor creates this chondrocyte response. Your chondrocytes are cells that are found in healthy cartilage, and then they help produce and maintain the cartilaginous matrix. So we have that injury though, we release more chondrocytes, and then they start releasing cytokines, and then those are stimulate the production and release of proteoglycic enzymes. So your collagenase, so that's what's happening. When those are activated, we start stimulating the production of collagen and proteoglycans and that kind of thing. But then that's going to result in damage and predisposes to further damage. And then you can see that, oh, now I've just started creating a cyclic response, which is just causing that constant inflammation. And that constant inflammation is then what's causing more chondrocytes to be released. And then I just keep going in this cycle and I kind of get caught. So you really start seeing a lot of issues that come with osteoarthritis. Okay, so speaking of issues with osteoarthritis, what are clinical manifestations here? You've got pain and stiffness and functional impairment. So it's aggravated by movement, but relieved by stress. Typically, they always wake up kind of with that morning stiffness that usually lasts about 30 minutes. And then as they get going and everything, then they start to ease up a little bit and it's not near as uncomfortable. And so the onset is insidious and slow over the years. It's not like you just wake up one morning with osteoarthritis. Like it's a slower onset. It's just that over time you start to see this because we get stuck in that cycle, and the more and more chondrocytes that are released, then the more inflammation. So then it's just that constant cycle. Then that's where you get the bone spurs and everything. So it just gets worse with time. You might see an enlarged joint with infusion and mild inflammation. You might see decreased range of motion in that joint. You don't usually see systemic symptoms, and it can be unilateral or bilateral. So if it's maybe more so related to like a joint repair or joint surgery because they had an injury or something like that, it might be more so unilateral. But if it's just from a laborious job where, maybe they laid tile and they was on their knees a lot, putting in tile and over several years, then you might see more of a bilateral osteoarthritis with that individual. So even though I don't have rheumatoid arthritis on this presentation, I do just very quickly want to point out the difference, not to get them confused, because that rheumatoid is that autoimmune arthritis and it's different, so we're not going to go into it. But there's a big difference. So osteoarthritis is very common. People with OA have that stiffness in the morning, usually lasts about 30 minutes. It will come back then at the end of the day. And then with RA, they typically have that pain much longer than just that first 30 minutes of the day. And then with osteoarthritis, it's usually like a sharp ache or burning sensation, which can also then get worse with like prolonged activity. But usually the joints don't necessarily swell. They can, but not necessarily is that a classic symptom. Whereas with RA, that typically has very painful swelling. So also, when we think about this, most commonly occurs in weight-bearing joints. So your knees, hips, cervical and lumbar spine, and then distal and proximal interphalangeal joints. So especially this is where you start seeing those individuals that maybe have a job where they work with their hands a lot. Just recently, I've been building my house, and the guy who puts in our shelving in our closets, he had terrible Herbrandens and Burchard's nodes on his hands, because again, this is just like I was saying, when you get that buildup and you start having that inflammation and that body's response to create those osteocytes, that's where you start seeing that in the joints. And the names for those are your Herbrandens and your Burchard's nodes that you see with these individuals. So assessment and diagnostic findings with OA. So our assessment, we're going to look, we can aspirate blood in the joint, like synovial fluids, and to rule out systemic disease such as RA. And then the imaging is most likely going to be x-rays, which is going to reveal that joint space narrowing. Again, you can kind of see from this picture, once I've lost that cartilage and I start, having issues with my synovial fluid, and you can see in the other picture how now I've got that big osteophyte and that bone spur that is then cause that joint space narrowing. So then I have that bone on bone in these individuals. You'll see those osteophytes, they'll see dense, thick subchondral bone. So that's that bone that's underneath the cartilage, and it's just trying to, it will thicken with OA because it's trying to just do whatever it can to help cushion the blow between those two joints. So then our medical management with OA. Our goal with OA, really there's not a lot you can do. We want to decrease the pain and stiffness. We want to improve joint mobility as much as possible, if possible, and we want to reduce stress on the joints to prevent degeneration. So the biggest things we can do is pain control pharmacologically with non-opioids, just such as acetaminophen or NSAIDs. Obviously, we need to be careful with our NSAIDs because it puts those patients at risk for GI bleeding or cardiovascular events. So we typically talk most about using Tylenol or your acetaminophen. It reduces the pain moderately, and that's, kind of the goal. You can get to where they'll start using opioids, articular steroids. So that's where you hear of people going to get cortisone shots. And then you see, like, you might have individuals where you've seen them have like Voltaren gel or those topical analgesics to try to help with that localized joint pain. So nursing management for us, the biggest thing we can promote is weight management and improve exercise, lower body strength training. Obviously, we're not like, hey, let's go hit up some hardcore weightlifting tomorrow, because that's not what we want to do. We want to do a slow introduction and then just ease into that and plan to exercise when pain is well managed. So if they're really in a lot of pain, we need to make sure we get the pain under control first, and then slowly introduce that exercise and then that strength training with those individuals. Stress reduction on the joint. So this might be individuals needing to use canes, walkers, that kind of thing to kind of help alleviate some of that joint pain, especially with like hips or knees, that kind of thing. Pain management, obviously non-pharmacological if we can, but then also pharmacological interventions as well. Like I said, so 85% of the population over 65 has OA. Also, as they get older, they're most likely to have a lot of other comorbidities that we have to take into account. So, if their heart is not strong enough to do a lot of exercise, then what kind of exercises can we introduce, and that kind of thing. But like I will say, one of the biggest modifiable preventative measures we can do with our patients is really try to help with weight management and doing low impact strength training to help improve just over time how that joint functions and to prevent it from getting worse.